I'm going to ask you, David, first. NHS is a system that I understand, having worked there and living in the UK. But I think, David, can we start by just asking you for a quick snapshot of the NHS, and in particular, the NHS was founded on this principle of equitable, universal health coverage, free at the point of delivery, which is an incredibly, some would say, rash promise to be making in this day and age, and yet it is still made. So give us a snapshot of the NHS and then tell us how that principle is sustainable. Is it sustainable? What's working?
Very happy to, and thanks for the invite for coming. It's really good to be here. I think there are obviously 6 other English people in the room voting for the UK. We tend to do well more broadly than that, so thank you for those. Absolutely right, Viv. I think the system we have in the UK, originally coming up in 1948 after the war, universal coverage, strong commitment that everybody would receive the care that they needed, still continuing today. Vast majority of providers are still publicly owned. My own membership organisation represents sort of private and not-for-profit providers, but that's still only around about 6.5–7% of overall service delivery. So the vast majority of provider base is publicly owned, funded out of general taxation, very minimal co-pay, a bit on dentistry, and prescription charges, and that's about it. Different system in social care, and we can possibly come on to that later on, because I think that does drive some slightly peculiar incentives when you have universal coverage on health care but not on social care, and we do know the divide between the two is challenging. The funding model, as discussed earlier on today, is a sort of interesting mix of capitated funding for primary care, which effectively incentivises very little, and activity-based payment in hospital care, which incentivises an awful lot. And again, in terms of aligning incentives, actually there are some challenges within the system that we have there. I think one of the potential opportunities that you do see derived from the system in England is geographical commissioning, which actually potentially allows for some of the challenges we were discussing in the first session to come through around place-based, looking more broadly than episodic care. Recent changes to that have meant that's been in a state of flux, but actually there is the potential there, I think, to do much more with it. In terms of how costs are controlled, staff pay is all set centrally by the government, and we've been through a period of extreme sort of pay restraint over the last 4 years of austerity. It'd be interesting to see whether that can continue, but that does enable cost control. And we also see in cost control largely done through rationing and extended wait times. There's a wonderful urban myth from the mid-1990s when wait times were significant, when a father said, I'll pass on my position in the wait time to my son. Such was the length of the waiting list. And they're beginning to rise again, and actually that is the way in which costs are largely controlled. So I think there are, and people are increasingly resistant to that. I think people, particularly from younger generations, are saying, why should I be waiting months and months and months for treatment when I'm in pain? And I think that is going to have to change, but that is largely how we've managed to effectively control costs within the service.
And can I ask you, you touched on this issue of going more broadly into some of the social determinants. I mean, in what way is the NHS tackling that? How is that being incentivised, or is it being incentivised?
I think it's probably one of the biggest challenges facing our health system in England. There's a huge amount of protection that goes around the NHS budget. I mean, Scotland will vote tomorrow on whether or not they want to seek independence from the United Kingdom, and a big shift in the opinion polls towards voting yes has been a push on, we want to keep the NHS free from the private sector, we want to keep our control of NHS. And it actually is a very interesting push that you're seeing from a country who are thinking, well, this is a fairly major decision to be making. The NHS is uppermost in their minds as to how they go about doing that. So I think there's some quite interesting discussions there in terms of those wider determinants of health. We really do need to be looking at, certainly in England, welfare austerity. Unemployment has not dropped as low as we feared it might do after the great crash, but nonetheless we are seeing people coming forward with, it's not been an issue discussed hugely today, mental health problems and the determinants and the drivers of that. And we do have a very episodic based care system which doesn't really look at the individual in the round. I think the hope is that more population based support, which we see in terms of how the services are commissioned. We never use the word bought in England, it's a bit too crude. How those services are commissioned will be really important in changing those determinants.
And if you were to pick out some of the elements within the National Health Service in England, the elements that are promoting the aims of better healthcare and better lives. I mean, what are the key things that seem to be working? And on the flip side, what do you think are the things that are going to cease to work or need substantial improvement?
Yeah, I think where, certainly over the last 10 to 15 years, we've made real strides is in children's health. You know, looking at things like free school meals and improving nutrition within schools and beginning to align much more effectively what goes on in education and children's services alongside healthcare. And I think that has driven a very strong change in the emphasis on children's healthcare. And I think that's been quite fundamental. But for us, I mean, there was a recent Commonwealth Fund study that came out looking at efficiencies of varying health systems. We actually did very well on efficiency, on access. I think that was important. But on healthy lives, we came well down, only beating one other country, which was the US, incidentally. You know, we have an awful long way to go before we actually get that proper wraparound care. We're able, I think, to be very efficient with the episodic hospital-based treatment that we've got. But we need to look much more clearly, I think, and I think the system is, you know, post the next year's general election, I think there'll be time to do more of that, look at actually how we can have much more examination of proper healthy lives and what that means beyond just children's health, where I say we've made pretty good strides in recent years.
I mean, and I think it's true to say that one of the barriers to achieving that is the fact that in the mind of the public, healthcare is about hospitals and about what we, you know, and about clinics and about doctors. And we can come back to this because I'm sure it's an issue globally, is as a result you get a lot of politicization around what is healthcare and you get ring fencing of NHS budgets, which means that takes away from some of the social developments that could happen.
Yeah, it's entirely right. I mean, you know, going back to the place-based commission, I mean, what you can have in terms of the provider market in that space is often a very large hospital with minimal other providers around that. So if you're buying care in that area, you have to protect that local hospital because of the politics around, you know, in any way downgrading the local acute estate. So whilst we don't have huge numbers more beds per head of population in other countries, the hospital is still uppermost in people's mind as the symbol of healthcare. We need clearly to move away from that, but I think that is proving very, very difficult. And you know, we see, you know, people on the streets campaigning against the closure of any hospital, even though actually when you look at the outcomes that hospital sometimes delivers, they're very, very dangerous and damaging. But nobody wants that hospital shut because, you know, my daughter had their child there or something like that, and actually it's very totemic for people in that locality. So making fundamental change to the NHS is really, really difficult. I mean, it was described by a former Chancellor of the Exchequer as the nearest thing the British have to a religion. And any attempts to try and change it are met with real fierce resistance from people, even if actually the provider that is delivering the care is potentially causing huge challenges. And you know, when we look in England around greater consumerism and trying to empower patients to make greater choices, there is not really the plurality of provision necessary to enable people to make significant choices, so they largely give up, and you have to rely on hoping there is a good local hospital, a good set of GP practices, and that will sustain you. Increasingly amongst the younger generation, they're just seeing that isn't acceptable, and people do want far more choice, not only just where they're provided, where their care is provided, but how they're treated, how they're supported, you know, and not just as a patient, but as a citizen as well.
Well, that's something I'd like to come back to actually, is this issue of empowerment to choose requires a great deal of transparency. And how do you achieve that transparency in a system so that the patients can, the public can actually choose what they want to do? So, you know, similarly, I mean, in Israel, I guess there are some parallels in that it's a tax-funded universal system. It achieves, I believe, excellent outcomes at relatively low cost. So what is the secret sauce, and in what ways is it not working?
Well, first let's start with the things that it does work. The Israeli healthcare system has been named by OECD as one of the best healthcare systems in the world. So it's a pity we didn't even appear in the vote. So there's a universal coverage. We pay 4.6% of our salary and to the National Insurance Institute, which is a governmental entity. We're talking about that previously, where money goes. So the money goes there. We have 4 health funds, non-for-profit, and they definitely don't make profit. And the money, the 4.6%, is divided among the 4 based on capitation. Now, all residents are insured, and each resident decides which HMO, which health funds he wants to enroll to. There's no health status discrimination. You can move from one health fund to another, and they need to provide services and accessibility, and they do. And they compete really on the quality of care. There's a health basket of benefits, which is pretty broad. Pretty much all that you need is there. Of course, not cosmetic surgeries and not extremely experimental drugs, which is updated annually in a very rigorous and thorough process because, of course, many, many technologies want to enter the basket due to financial reasons. So we have a basket, it's updated, and the health funds are obliged to provide it to all their residents with no discrimination. And that's something that the law, the health insurance law, is very keen about. It's not that I'm your friend, so I'll give you this medication out of the basket. Because once I did it for one, I'm obliged to do it for all. So the equity part is very strong, and it works. Health status. Life expectancy in Israel is very high. It's 4 years longer, actually, than in the US. You're welcome to move over. And of course, women outlive men, as always. Immunization rate is very high. There's low rate of ischemic heart mortality due to ischemic heart disease and CVAs, in one case, due to the community-based integrated care system that is a very, very strong one, including EMR, which is very advanced in the health and in the community care. And we do all that with only 7.7% of our GDP. So it sounds great. So how come? So first of all, I think the fact that the community-based integrated care is very strong makes a big difference. A patient has an access. There are quality indicators, and they were talking about quality before. There's national quality indicators in the community-based, which are very pronounced, and in the last few years in the hospital-based system as well. And it's transparent. And there's regulation, which means that the government, the Ministry of Health, regulates the number of beds. Because we know in medicine that an empty bed is a full bed and that there's a supply-induced demand. So we practically can determine our demand as hospital directors, so that's why it's regulated. The other thing is the expensive equipment. MRIs, for example, is under certificate of need, and the numbers, I can tell you they're too low now. We have 2.5 MRIs per million population. Here in the US, it's 31. And it's second after Japan, we have something like 40-something. Now, of course, it drives the number of tests that are being done. So if you look at number of MRI tests per 1,000 population, it's 19 in Israel, and it's 105 in the US. And we still remember that the health outcomes in Israel are very good. So how come? Is it always good? No. I think that we do probably expose our patients to more radiation in some instances. Instead of doing an MRI, you'll do a CT scan because of availability. But you do, as physicians, you do think twice before you send a patient to an MRI. And that's an MRI, just for example. Waiting times are luckily not long for surgeries, even hip replacements and so forth. They can be a few months. And accessibility to physicians, it's very easy. The other thing which is good is that the payment, it's a very simple payment system. I mean, we're reimbursed, the hospitals are reimbursed by the health funds based on either DRG or per diem, but it covers everything. So you don't get a few billings. We directly deal with the health funds. The patient is not part of the billing issue. The only thing, there's a little co-payment. They pay about $4 per quarterly for office visits, but that's really something which is not a lot. And so you go in, there's no co-payments for hospital admissions. So that makes it more simple. The other thing is that there's a tariff. There's a regulated tariff decided. Everyone comes, all the stakeholders come to one of the committees, fight, argue, like a Turkish bazaar, and then they get to a set price for DRG. So that's the maximum price. You can't charge more. You can charge less, and then we start negotiations with the health funds, negotiations, and again, we get to the bazaar, and then that's the price that we really get from the health funds. The last thing is the capping system. In order for, again, to control the supply-induced demand, there is a cap based on the activity of the prior 3 years between each health fund and each hospital. So that's the 100%. Beyond that, if they do more activities, they pay us only 30%. So the hospital, that's where there's a conflict of interest, because the health funds would like to then use it more, and we would like, because that's 30% we're losing. And then after a tire of 30%, we get 70%, so the incentives will play back again. But we do have a lot of issues. The 7.7% of our GDP is too low, which means that everyone's losing money. The Ministry of Finance are very happy about this number, and they're very proud, and they're saying, what do you want? We have such wonderful health outcomes. Why do you want more money? And because in Israel we have all our defense issues in it, and that costs a lot of money. So that's the thing. And we in medicine, as a physician, trying to tell them it's not just about money. It's not just about the indicators. The indicators don't tell the whole story. And we want, again, to look at the holistic approach and the patient-centered care, which we discussed before. And for that, you need more time. The other thing is we are having a shortage of nurses and physicians in Israel, which is bad, and it will grow even harder. And the other thing is that we have a great increase in the out-of-pocket and private expenditure, which comes up to now about 40%. Dental care is not included in the basket. Now it includes for kids till the age of 12, but in general it doesn't, and that's a lot of money. And there are lots of additional private insurances, which practically no one doesn't really need, but we're all risk avert, and I have probably triple the insurances that I really need, and we don't use it. But that's another thing, that there's a big disorganization in the insurance part. So you can, God knows what will happen. So let's just have this insurance for the special drugs and special surgeries abroad and so forth. And there's no need, and increases the private expenditure.
So you described there. One of the things I wanted to pick up on was you described how the reimbursement mechanism is moved from a fee-for-service model to a DRG model. So that helps to kind of risk share and hopefully deliver better care. But in what ways are the quality metrics built into how is quality being reimbursed? And a question to both of you really within these systems. In what way is that explicitly being addressed?
Yeah, I think what one of our sort of health regulators, the Care Quality Commission, has recently been bolstered significantly to go in and inspect all providers of NHS-funded services. Now, that'll be private, not-for-profit, and public. We've always had an inspection regime, but following a fairly sort of significant hospital scandal that we had a few years ago, this has been beefed up dramatically, and actually the kind of quality indicators they're looking at are significant, and for the first time, and I think quite importantly, looking at things like workforce morale, staff absenteeism, really trying to drill down into how the workforce act in a particular provider base, and then providing a report back on that provider, which could potentially lead to long-term sort of sanctions. So there is a much more of a sort of deep dive approach into individual providers on quality outcomes, and providers are forced to report more on what are called patient-reported outcome measures nationally, and then they are published. I think one of the challenges, and we might move on to this around transparency, is there's a huge amount of information published, but actually the extent to which patients then engage in that and then make meaningful choices as a consequence, we seem to have got to a place where we just put an awful lot out there and then hope people will analyse it, rather than actually making it easier to do it for them. And I think there is a real need, look at the iTriage stuff from earlier on. We have I Want Great Care in England, to try and help patients understand and make sense of what is now an increasing amount of information on quality, to help them make further choices, along with changes to the provider base to make it more plural, to enable those choices to be genuinely meaningful.
Mm. And what about in Israel? What are the...
Let's differentiate between the hospital system and the community-based system. So in the hospital system, now we don't, we're, for the never events, those, wrong side surgery, we have the list of never events. We're supposed to not be paid by the health funds. It doesn't really work, but of course we don't come up and say, please don't pay me because I did this mistake or so. But that's in place. It should be that we're not getting paid for never events. In the community-based care, the physicians do get some kind of financial incentive based on their quality of indicators. either it's hemoglobin A1C level, mammogram screening, and so forth. So that's one of the quality. And the other thing is that it is transparent. But as David said, people don't really, I mean, in Israel, it's very easy to move from one health fund to another. You just go to the post office and you can move. How many people move? 2%, 1%. Because we're all conservative, and that's where I've been as a child, and that's where I stay, and that's my physician, and so forth. But in general, that's a competition that quality does drive it. So we're looking, and the other thing is transparency. The transparency only started a few years ago, and with the hospital quality of indicators, which I'm part of the national committee, we had the big discussions because hospital CEOs are not too happy about all this publicity. And another thing is, of course, how the public will be able to understand what's happening. I mean, if you're saying that there's an infectious rate of, every percent of the public seems awful, and it is awful, but as physicians, we know that there are some things that you can't get to a zero tolerance, so zero number. So it's complex, but I think we are going there, and the quality of the care is receiving more and more importance in the healthcare.
Mm. Let's shift tack a little bit. I want to talk about I think we did touch on it earlier, about the politicization of healthcare, and to what extent, I mean, there are several cultural issues that I think raise their head when you talk about healthcare. Is this, I think it's common for the public, you said, as a matter of, as a positive thing, there's fewer MRIs done. Now, I think if you ask the members of the public, they might say, well, we're being denied care, that there's an equation of more care equals better care, which isn't necessarily the case. So I mean, there's several issues like this that sort of dog healthcare, and then it gets played out in political circles, and that can reinforce some of the entrenched problems and reinforce the siloing of healthcare and actual wellness and management of the public, so to prevent disease. So, I mean, to what extent does that actually play in these two different systems?
Well, I think that it was when I was thinking prior to this wonderful event and we were talking about it on the phone, what can be applied to the U.S.? And I was thinking, looking at the Israeli system, and knowing I worked here, so I know the American system, and I'm saying, what could be applied? So I would love to the tuition would be applied, because we pay $4,000 to go to medical school per year, which again, it drives later on the salaries and everything, but that's one thing, of course, that would be hard to apply here. But one thing is the culture. And I think that's in Israel, it's not, I mean, and I think that the limitation of resources is way too much. And the GDP, the health expenditure is way too low because we are feeling it. But the culture is that people know that in order to get an MRI, they have to do certain things. And it's not just, I remember we lived here and my son had a skiing injury, and I came to the doctor and said, okay, let's have an MRI. I said, really? It's that bad? And we're both physicians, my husband and I. Said, no, what's the big deal? I mean, he says, where? I said, we lived in Boston. I said, oh, you have this 5 places to choose from to do it today. And and I asked him, I said, do you really think that you need so many MRIs here around? And of course, Boston has, with all the medical facilities, has a lot more than the 31 per million. And he says, no, but I know that if I won't give the pay, that's the culture. The culture is if there's a back pain of a few days, he'll get an MRI. In Israel, there's no such a thing. So it's a different culture, and that's why it's not an issue in Israel, that part. There is some bureaucracy that is annoying, and people, but and that's something but it's not a cry of the public to say, let's change it.
Mm. What about in England?
I think the politics of the NHS is probably one of the most difficult political issues that we face in England generally. We're going towards a general election. My members are for profit, not for profit. We're having this ongoing debate around privatisation. Is the NHS being privatised? When actually what we're seeing is contracts going to private organisations still very small. And that debate really overshadows pretty much anything and makes it very difficult to change things. things. I think we all, in England, we also need to understand the drivers of why politicians are saying what they're saying. So the Labour Party, who actually did more to introduce more market-based system, more transparency, more consumerism, when they were in power between 97 and 2010, more towards the end of that period than the start, admittedly, are largely funded and are going to be 95% funded in the run to the next election by the trade unions. And trade union power within the NHS is reasonably significant, and the Conservative Party, who are currently in office in the coalition, are not as trusted to make changes to the NHS because they're not seen as committed to it. So you end up in a place where actually nobody wants to make fundamental change and have an honest conversation with the public about all the kind of shifts in policy priorities that we need to have. It's always after an election, maybe we will look to do it, but that doesn't tend to occur, rather just then delaying where we need to be. And it feels like whilst we might have fairly efficient and effective systems around individual unit parts of the health service, actually the dam is going to burst. And I think there's real fear that the money isn't going to be there in order to sort that out. The debate now is around how you fund the health service moving forward. There's a debate around whether we should be increasing taxes significantly. Public generally say, yes, we're up for increasing taxes, but don't tax me anymore, and you can only tax those nasty bankers so many times. So actually, that debate, will probably not lead to more taxes. There is a bit of a debate around sin taxes. Probably around 15% of the NHS budget is funded by things like alcohol duty or tobacco duty. Can we look to extend that to fatty foods or whatever? But actually that's a very difficult thing to do. Can we extend co-payment? But the politics of that are very difficult, because that's then just the road down to the end of the universal element of the health service. So actually it is getting in the way in England of making fundamental change. But I suspect some of the demographic challenges, some of the comorbidity challenges that we all know we're going to face will drive that change. It will just be in the teeth of a crisis rather than in a planned way.
I want to open this out to the floor. If anyone, because these are obviously very, very different systems to what's here in the US. Any comments or questions, comments about any commonalities that you're seeing, or anything that you feel that, just wouldn't wash here. It's not gonna, or things that you feel are working and you wish they could apply here. Anyone got any comments on that? Yeah. Or questions? Please say who you are.
Isaac Giroudi, I'm from Tufts Health Plan, a local health plan. Just a question about the MRIs and how they're limited in Israel. Does a comment you'll hear a lot here, if we went with that policy, is, well, it's about defensive medicine. People are prescribing these MRIs because they're afraid of getting sued. I don't think the studies support that as a major factor, more than incentives, but I was curious about the debate in Israel. Does that ever come up? If you're in a circumstance where something's not caught that could have been caught by an MRI, treated it earlier, does it lead to any kind of political debate, or is that contained?
So unfortunately, we're really catching up after the American system. There's a huge issue of malpractice suits in Israel. The compensation that is decided by the judges is horrific. I think we're at the stage in America, it's already about steadied. Now we're still going up. So that's a big deal. There is defensive medicine. And although we do know in medicine that when there's a saying said, when there's no indication, there's complication. You do something you don't need to do, and then you start a cascade of things that come up. But we do have defensive medicine. And and the judges later on, when they're in the court, they forget that there's 2.5 MRIs per million population. They forget the shortage of doctors. That when you're in court and you have to defend the case, it seems as if you're in an optimistic world with all the, that every patient in the ED can be monitored like in an ICU. And so we're really facing it. We're trying to work on different issues, no fault, and so forth, other mechanisms that other systems in the world have it. But of course, the lawyers are very much against it. And we are currently not doing much progress in that issue. So it's a big deal. It's a lot of money. And it's a money that, as a CEO who's dealing with risk management, I said to myself, if I pay a few millions and there's no take-home message, then we have a problem. And I think we do have a problem in the way that it works now.
Yeah. microphone across. Thank you.
Just one thing about the risk of the insurance company. Insurance, it doesn't come out of the doctor's pocket. So it's not, so we do still have the OBGYN is a very successful profession. So he doesn't really feel it out of his pocket.
So in the United States, and particularly here in Massachusetts, health systems keep getting bigger and taking on other hospitals. And is that happening in Israel or in the UK? Is Hadassah going to take over all the hospitals in Israel?
Well, in Israel, actually, it's pretty much, I didn't touch it, but the hospitals are divided into a few kind of ownership. Many are governmental-owned hospitals. And then the largest health fund has about 8 hospitals of their own. So they have already the volume, the purchase ability, the negotiation ability with the health fund. So it's really much, and then we have not many hospitals, which Hadassah is the biggest of, which we are privately owned public hospitals. Hadassah is owned by the Hadassah Women's Zionist Organization of America. So but that's the entity of only a few of the hospitals in Israel, but the majority belong either to the government or to the health funds, and that's the answer.
Yeah, certainly in England, I mean, we're seeing far more moves to try and network hospitals together. I mean, some of the biggest hospitals in England, have turnover of well over £1 billion, are enormous entities, particularly when compared to the size of the local health economy. There is a bit of a fear in some cases of too big to fail. But often act in isolation from other hospitals in the rest of the country. And so there's a fairly major review underway at the moment looking at how those hospitals can work far more closely together. We've got a number of sort of small to medium-sized district general hospitals, as they're called, which maybe do sort of pretty small numbers of procedures, something like, we've got a couple of examples of maybe 100 maternity procedures a year, something like that, which clinically is very, concerning. So looking at how we can network some of those together without shutting them down, because it goes back to the point about the politics, actually. As soon as you start shutting down hospitals, actually you get the people with the placards and you've wasted 5 years. So it's looking at how you can sort of wrap an arm round and work in a networked way, which is far more efficient. And I think we'll start to see the blurring of the boundaries between private and public. One thing that's happened in the last few years is public hospitals, publicly owned hospitals, are delivering significantly more private-based care, particularly in London, to those sort of wealthy global elites who sort of fly in for treatment and fly out again. And there'll come a point when actually privately owned providers, potentially in my membership, are actually delivering less public sort of private work than some of the public ones. So I think the blurring of the boundaries will happen, but it will take an awful long time in order for that networked mentality to come forward. It'll be interesting to see where it goes with that, because then you're creating brands of hospitals as distinct from a geographically specific hospital in wherever it may be. So I think that change will come, but it will take time.
And when you talk about networks, are you talking about collaboration or formal merger or acquisition of these hospitals?
Probably more the former rather than the latter. There have been moves in recent times to try and merge hospitals. That does come up against competition law a lot, because you're talking about, as I say, large, too big to fail hospitals, which when you get the competition authorities involved will say, well, actually, there is therefore even less competition in this area, so they'll block that move. So that has been an issue. I think we're looking more at, horrible phrase, it's used, buddying, it's called, as a starter for 10, but looking at how people can work together to try and sort out financially troubled hospitals. But to give an indication of the financial picture in English hospitals, over half of them are planning or forecasting deficits for the financial year that we're currently in. So the current model of a lack of efficiencies working together, economies of scale, I think is going to have to change fairly fundamentally over the next few years. Otherwise, we are going to see them falling over, and even more bailout payments being made by the Exchequer. In the last financial year, around £650 million of non-recurrent spend was given to hospitals in England just to keep them going, and partly because of the point we are in the electoral cycle. But the public aren't going to support that for too much longer.
Any other questions? Yes.
My name is Laura Bush, and I work for Sun Life Financial. And I'm just interested here, there's a lot of talk about having to put more costs onto the patients so that you've got aligned incentives, so that someone who tends to overuse care has to pay something for it. And it sounds like in Israel, the costs are very low and there's not overuse. Is that just controlled through the culture of the doctors, or are there more sort of controls in place? It sounds like in the UK it's limited by waiting time.
Well, in Israel, actually, you have probably the older population that still goes to the doctor as part of the routine day and see all the friends there, and it's part of the, and the doctors actually are, the way that they're paid by the health funds is either per capitation, so they have no incentive to overuse and to invite the patient to more and more visits. So that's one thing, or per number of patients. That's per capitation or as salaried. So they don't have incentive to see more and more and more. Especially, it depends, of course, it varies between the professions. Dermatologists, if they're paid paid every quarter, and they get, whenever they pass the card, they get 100 shekels or whatever, then of course the next time they'll invite the patient for a checkup would be 3 months and a day, because that's where the incentive comes. I think it really, the usage of, and we do have one thing that is, if I'm thinking of a hospital, so they do come to the community-based and to the GP a lot. And the other thing is that there's very good and very high quality of personalization relationship between the patient. Not only that regards compliance, the health funds also have a system within the pharmacies to know that if the patient didn't buy the medication or something, there's a mismatch, to go over and see what's the problem. But there is an issue, but for example, coming to the emergency department, there are certain criteria that you can come directly to the emergency department with no copayment. But if you don't fall under these circumstances, you do have a copayment of about $200 to even more, which is not a small amount, and then you need to go back to your doctor and start arguing and trying to have the health funds cover it. So that is a way of reducing misuse of the ED.